share our thoughts.
Yeah, just listening to the presentations, and I guess I went to one of the desks here. It seems that a lot of responsibility in terms of the course of treatment is being placed on the patient. Basically saying, you need to come in with, how about this, how about that? And that would appear that you have to have some knowledge beforehand about what the various treatments are before you actually discuss them satisfactorily with the physician.
So I think that patients are all come in all sort of shapes and sizes. I think that part of it is how what is the way to make you feel most comfortable about the treatment decisions you have to make? Because typically you go somewhere, you know you've been diagnosed with something, and so you have to figure out what are we going to do about it. So there are some people who come in and they will bring in, you know, a folder this thick of stuff that they pulled from the internet, right? And some people will come in and say, I don't know anything about myeloma. I actually don't want to learn anything about myeloma. I just want you to tell me what I should do.
Right.
So it goes the entire gamut. So I think part of it is how comfortable a person is with like the information. I think that the information is really great for some people. I think it's super overwhelming for other people because there's like many options out there. And the one thing I will say is that if someone says, well, I think we should do X, right? And this is sort of the reason why. I think it's always a fair question to say, look, well, what will be our other options? What would be other things? And I think that that is a super fair question. I think that the other thing that I always like people to know is that, look, if you are a person who needs to hear things in a couple of different times in a couple of different ways, right? Like we are all, it's not like we're a mafia or anything, but I am never worried about someone going to another myeloma doctor and saying, look, well, what do you think about my case? What do you think we should do? And so I think we all have different experiences. I think we all have we look at, you could have one piece of data that we might look at in different ways. And so I think I think people worry that asking for like a second opinion is showing that you're not confident in your doctor. I'm like, look, I would like you to be as sure as you are about the decisions that you're making. So if that entails going and seeing someone else, I don't think I've ever told a patient, no, you shouldn't go and see somebody else. I think that that's your prerogative. So I think that like in terms of like how much knowledge should you arm yourself with when you go in, I think that it is, like I said, it depends on who you are. Like my parents are two examples where like one is never going to make a decision no matter how much information they get. The other one never wants to doesn't want to make a decision and just wants to be told what to do. So I think there's a whole host of things. I remember once I had a patient who was like a very famous person they had leukemia, they didn't have myeloma, but it was a person who was a very famous biostatistician, has designed all these clinical trials and worked on all these clinical trials, knew all about data and all of these other things. And then I saw them because I was talking to them about bone marrow transplant. And so I was prepared myself by having all of this data and knowing everything about it. And I sat down and he said, look, I don't care about the data. I just want your opinion about what you think I should do. So I think it all is variable, and there are a lot of choices. I think it's much better now than it was 20 years ago, where it was very difficult to get information. Like there was no internet at some point. But I think that one of the jobs we have now is for when people bring in information is to help them understand that information. So it's like up to you. It's up to you how we want to do it, right? But I think that I always think that people coming in with some knowledge of the disease, I expect them to have something. I think that people will have looked something up. But and a good way to
get to know them is to sort of, oftentimes say, look, well, what is your understanding of this? And where should we go? What are your thoughts along the way? So it's different for every person, but that's sort of the approach. Go ahead.
You first. Okay, want to learn as much as I can, but I can't start at, the medical journal articles level because it's not going to make any sense. Do you have a recommendation for resources that, kind of bring it down to a children's book level and then build on to kind of understand it?
Yeah, I think that one of the, I'm like not this big, huge fan of AI, like I think, but I think if you feed an article into like ChatGPT and say, can you give me an explanation of what happened in this paper, I think that is actually pretty accurate. Sometimes it's not completely accurate, but that actually is quite good. Like there are papers that I read where I'm not really sure what's going on here, and I will do that. I think that's one way to do it. I think the other way is that if you find, oftentimes, like let's say there's a study, the title of the study or the trial, and you enter that in Google, what you'll do is you might get the paper that is written about it, but then you can also get people who are like being interviewed about that research, or so there's like a video or there's a transcript or something where they are explaining it. So typically it's the person who's run the trial. They say, look, can you talk to us about these things? A good time to do that is oftentimes there's a couple of really big meetings for myeloma every year, every couple of years. One is American Society of Hematology. That is a international meeting that happens once a year the first weekend of December. So it's coming up. It's in Orlando this year. And it's about 15 to 20,000 people. They're not all myeloma people, but they're all interested in blood and blood cancers. Go there. And so things are presented there. And then oftentimes you'll have like sort of news stories about what's presented there. So they will explain about what happened or what their understanding is of what the trial is. And so you can find videos about that, like HealthTree does a lot where they actually produce videos. The International Myeloma Foundation does the same thing. And so those are ways, it's not dumbing it down, but I think it's like really cutting it down to the chase. Like what are they studying? What is the outcome? How does it change the way we think about approaching myeloma? I think at some point, there may be where you put in your own sort of history and you say, here's a paper, is it relevant to me or not? And how, like, ideally at some point we get to that. I don't think we're there yet, but those are ways to sort of distill it down. Like I think you use AI to do it, or just go back through Google and sort of say, what about this? And you'll find explanations of it that are beyond like just the dense paper that was written and in some journal, because that's hard and it's like tedious and there's a lot of information there that I think may not be relevant. Another?
So I'm in a situation where I'm not at the point of the diagnosis, and I'm just confused because I guess working just with hematology, don't know if it's multiple myeloma versus leukemia, so it's kind of, so I guess my question is, when the M protein comes out on the blood work, does that mean multiple myeloma? Does that even mean cancer if it comes back repeatedly? So that's kind of like the starter question. Does IgM showing up high plays into any of it? So I'm just sort of trying to get a little bit better sense.
Yeah, so I think that, as what was the first presentation was all about sort of how do you, distinguish one thing from another. And so I think that having just a normal M spike, right, is a very, 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 very common thing. It's, so one way to think about it is that if that is between, let's say, 3 to 5% of the population over a certain age, right, that would be millions of people, right, in the United States. But if we think about the number of cases of myeloma that are diagnosed, it's like 30,000, right, in the United States a year. So it ends up being that there are a lot of people who have this thing, but don't have the actual cancer. And so one of the I think things that's really difficult for like, I remember when I was training, I like just could not understand this concept of you have something, it looks like cancer, and you don't do anything about it, right? And I was like, okay, so you have, if something, it's, even if it is sort of early stage cancer, you're not going to do anything about it. This doesn't make any sense to me, right? Because there's a problem, and so you should do something. So I think part of it is how do you sort of approach that? So the analogy I'd like to use a lot about sort of precursor states is like the difference between having like a mole, which like a lot of people have moles, and then moles can become melanoma, but it's not like a ton of people have melanoma, right? So many more people have moles than melanoma. So I think that one of the interesting scientific questions is that, well, what makes the difference between those two, right? And what changes one thing into another? So that's a lot of what people are trying to do now. But just having an M protein that we can see is so common, right? And
Alpha has to be over a certain threshold for it to again be working towards, because there are bone marrow changes observable over years
Yeah.
as far as mutations.
So the way that we define it is that to have myeloma, the easiest way to sort of define it is that is it affecting your body, right? So this is where the CRAB criteria come in. So if you end up having things like, so the CRAB things are like if your calcium is high, your calcium can be high because the myeloma is in your bones, and your bones are the major storage place for your calcium. So if it's in there, then your bones will start to release calcium, and your calcium levels in your blood could be high. It could be that you have anemia would be one of the things. It could be that you have kidney dysfunction, right? That's one of the things. You could have, sometimes people present where they were doing something and they broke a bone. And so you could have bone disease as one of those things. So those are sort of the four cardinal things that we look for in patients who we think might have something. But just because you have elevated light chains, I think that it is not necessarily that you have the diagnosis. So the one thing about light chains I think that's interesting is that this test where you look for an M spike, that test has been around for like almost 100 years. It's a super archaic test. And so what I tell people is that test is so old that you do this test, there's not a machine that sort of, you do it on a machine, but then a human has to look at something and say, aha, well, this is the M protein, and this is how big it is, and this is what the size is. And like in this day and age, you're like, well, what? There's not a machine that tells you all of that? No, it's a person who reads it. So that's why if you go from one lab to another lab, your M protein might change because there's a different person reading it, not because the numbers change. So with light chains, there's a specific test that's done. That test has come out in the lifetime that I've been taking care of myeloma patients. So if people had light chain disease before, the way we detected it was for them to collect a 24-hour urine because the light chains will go into the urine. That is the only way you could measure it. So if you had light chain disease, you would drive people crazy because they would have to do a 24-hour urine every month, and they would say, look, this is totally insane. So the light chain, having abnormal light chains has been something that is sort of a newer test. So if you use that test, now besides just doing sort of the M spike test, you sort of double the number of patients, number of people. They're not patients yet, they're people who have abnormalities there. So just because they have abnormalities doesn't necessarily mean they have the disease. There is now a place where between MGUS, which is really just seeing these things but having nothing going on, versus having myeloma where you see these things and you have like anemia or you have renal things that are because of the cancer, right? So there's a smoldering myeloma category that everyone talks about. There, I think there are a couple things to remember there. One is that there are certain things when people have looked at that, even if you don't have these CRAB criteria, if your light chain ratio is above 100, that might be something where people will say, look, your chances of developing actual myeloma are like 90% in the next like 2 years, and so we're gonna start treating people early. So that would be one. If we do a bone marrow and like the percentage of plasma cells is 70%, that's a very high chance you're gonna go to myeloma, and so that might be something. But here again, I would sort of say, you know, we've all taken care of patients where they have smoldering disease, they feel fine, they don't want to be treated, and we just sort of watch them. And you got to remember that even in the highest sort of chance of getting from smoldering to actual myeloma, if you take out this light chain thing and this plasmacytosis thing, there's still like about 20 to 25% of people that never get the disease, right? And so I'm a little bit different than other folks where people say, if you have high-risk smoldering myeloma, you should go get treated. And I'm like, okay, well, one thing we're taught in medical school is to do no harm. And so if you're treating someone, they might get the disease, but they don't yet have the disease. If it depends on what the treatment, if the treatment is going to hurt them, I would say, look, I would just watch them. I think that's too risky, right? I think that if it's something like taking a spoonful of sugar every day, then I would say, okay, fine, because there's little downside to that. But if there's anything that could hurt the person, I would say, look, I would be very careful about that. So I'm a person who tends to watch people more than treat right away. So like people have different, and you can talk to your doctors about this, people have different philosophies about how to treat. So one of the things is that if I don't know what's going on, right, I would rather not treat. I'd rather figure it out. There are other people who are super aggressive that say, oh, that might be the cancer, so I'm going to go and treat. I don't do that. I've never done that because my fear is that I'm going to hurt the person, and that's not why I went to medical school, right? So I think that it has a little bit to do with who's treating. I think it has a little bit to do with sort of where you are, but I've had people who, have had smoldering myeloma, kind of really gotten into myeloma, and we're still talking about should we do something or not, and then we finally do something a year later, and they say, oh my God, I feel so much better now that it's been treated. And I'm like, okay, well, that's what we should do. But just because it is something, it's not like you have to make a decision that day. Myeloma is a slower moving disease. And so I think 9 times out of 10, you have a chance to get good data, make good decisions, right? But it's not like there are other diseases like bad leukemia where you get it, you got to do something like right then and there. You don't have time to wait. So myeloma is a little bit slower, so we need to use that time to make good decisions.
If you don't mind, I'll ask one more question.
Yeah.
So I'm at the point where my platelets keep dropping very, very low. And again, this might actually look more like leukemia than multiple myeloma. Like there's some stuff that might be pointing to that direction, but it's not clear. So when your platelets start to drop, when you start to get a little bit anemic on and off, is there something that differentiates more where you are more leukemia than multiple myeloma? Is there something to watch for?
So the question is, if you have sort of cytopenias and you're trying to wonder what that's from, like I think it's like less typical that you have platelet issues if you have myeloma than if you have leukemia, right? And so the one hard one is anemia, right? Because you could have anemia from leukemia, you could have anemia from myeloma, you could have anemia because you don't have enough iron in your diet, you could have anemia because you have chronic bleeding, like you can have anemia. So anemia, I think, is a really, really, really tough one to deal with. If you have bone disease, the imaging we do is sensitive enough to pick that up. So I think that's not a problem. If you have kidney problems, like people don't like this, but sometimes we'll do a kidney biopsy to say, is this because of your myeloma or is this because of something else, right? But like blood counts are really, really, really tough, right? And so I think it's like sort of a best guess as to what might be the issue. And there are sort of pre-leukemias where you can see sort of things, but they're not, your blood counts are not so low that you need to treat. And so I think blood counts are like a super, super hard thing to try to wrap your head around. But as long as they're not so low that you're at an excess risk of bleeding, right? I would say, okay, well, you have a little bit of time to figure out, see what happens, because it may not drop below a certain point where it's dangerous, and you sort of say, okay, well, I have low platelets, but it's not going to hurt me.
We have 5 more minutes. We're
Oh,
going to try
sorry.
to
Sorry.
get 2
Yep.
more questions.
First of all, thank you for being here. We really
Sure.
appreciate that in this Q&A. So I have smoldering. I was diagnosed a couple years ago. I saw you back then, and I really liked your approach. It was very different than what I was hearing at MD Anderson, where they were much more aggressive. I'm low risk smoldering. Marjorie here will ask another question, and she's higher risk. So during that 2-year time frame, there's been a little change in the smoldering.
Yep.
We have daratumumab, which when I dug into it, while it can be an option, it seems like it's just a progression-free, prolonging the time for progression. More recently, there has been teclistamab and daratumumab as a combination. We're seeing that they're actually seeing 100% MRD negativity. And so given what you just mentioned, I know we want to have a lighter approach. I'm still low risk, so I'm not in that category. But I'm just wondering for folks who are at a higher category, what are your thoughts now around something like that?
Yeah, I think that so there was a time where folks thought that, so if you think about like colon cancer, the colon cancer starts as a polyp. So if you have a colonoscopy, they go in, they take out the polyp, and then your risk from that becoming colon cancer is gone, right? So what people would say is that like MGUS or smoldering myeloma is a chance to cure the patient because it's at a lower level, right? So that was one of the thoughts. I think that, if the myeloma is not curable, then I don't think the precursor condition is either. That's my own opinion. That's just the way that diseases work. So you could cure, like we could do, like I do, my sort of things I've done have been like bone marrow transplants using other donors, which are much more dangerous. Allogeneic donors, you can cure myeloma with an allogeneic donor. You could probably cure smoldering myeloma with an allogeneic donor. You could probably cure MGUS with that, but no one would ever do it because the risk of dying from an allo transplant is about 15% the first 6 months. So you wouldn't do that from MGUS where you think, God, I might never get the disease. So I think that part, I think, is not clear. I think that whether or not you treat it earlier, you're gonna cure it or not. Like my bias is just knowing sort of how cancer works. I don't think it is. I think that doing things early, like I said, there's this 20% of people, even if you have the highest risk, never end up having myeloma, right? And I think that in that, if you look at how smoldering works, it's like most of the patients, if they're gonna get myeloma after they get diagnosed with smoldering, are gonna get in the first 5 years. If you don't get it after 5 years, it's kind of like you're back to MGUS where it's like 1% per year, right? The early part, it's like 10% per year. So if you make it past that, then I think I'm like, okay, you're like MGUS, you're smoldering. If you get myeloma, we're gonna be able to treat it, but I would say, look, it's time that actually helps you here distinguish those two things. So I have someone who has smoldering myeloma for like 20 years and they're like, okay, should I go do something? I'm like, you've had smoldering myeloma for 20 years, right? And your number's exactly the same as it was 10 years ago. So the answer is no. I don't think that we should do it. So I think that time helps you a little bit.
Yeah, I'm going to wrap up with this last question.
Real quick. Okay, bone marrow biopsy versus the blood test. Is that a newer thing that they're doing? And how many people are actually doing this? Because they still are asking us to do bone marrow biopsy.
Yeah, so this is a great question because nobody likes doing bone marrows. There's a test that is being done primarily at the Mayo Clinic where they go and they use a very, very sensitive test to look for your M protein or your light chain. That is still remains to be seen how that matches up with people's bone marrow. So here again, if I do a bone marrow, I do them typically when people relapse, and part of it is just to look at their genes again to see if they're different now. You can't do that through the blood. It's harder to do, but I think that if we come up with monitoring like that, especially for minimal residual disease testing, I think that would be a game changer because you could test that every 6 months to a year. If you have MRD negativity that is like 6 months and you lose it, well, you're going to relapse. If you have MRD that goes for 5 years and you're still negative, I would say, I don't know, maybe it'll come back, but I don't know when. So I think that the timing of it here again is an important thing. So the one thing that we in myeloma have that other diseases don't have is you can use time to help clarify things. So you should, I think, like for someone to get diagnosed and then go on to therapy the next day, there's some instances like your kidneys are failing, but for other things, just take the time to like really get good information about it.